Conservative management of lumbar spinal stenosis. First, let's review the basics of lumbar spinal stenosis. It's caused by age-related degenerative changes leading to spinal canal narrowing, resulting in decreased blood flow to the nerve roots. Neurogenic claudication leads to symptoms of leg pain, heaviness or weakness and/or numbness and tingling, provoked by standing and walking and relieved by sitting and bending forward, especially during walking, as compared to vascular claudication caused by atherosclerosis, leading to a decrease in blood supply to muscle, provoked by walking and relieved by rest. Lumbar spinal stenosis is the most common reason for spine surgery in older adults. Pain and weakness while walking is the most common reason for seeking care in lumbar spinal stenosis and is associated with increased levels of depression, anxiety, and hopelessness. The number of individuals affected is increasing due to an aging population. The title of the publication we will review is Comprehensive Non-Surgical Treatment versus Self-Directed Care to Improve Walking Ability in Lumbar Spinal Stenosis, a randomized trial. The study is approved for publication in 2018 in the journal Archives of Physical Medicine and Rehabilitation. Note that half of the researchers are both DCs and PhDs. The majority of individuals with lumbar spinal stenosis receive non-surgical care. However, systematic reviews have demonstrated no benefit, including the ability to improve walking outcomes. And the natural history of lumbar spinal stenosis suggests no significant improvement in walking ability over time. So the current study's researchers were interested in knowing whether a comprehensive approach that included exercise and chiropractic manual procedures would have an effect compared to those receiving only education and home exercise instruction. Patients were referred from specialists, family physicians, and chiropractors. The inclusion criteria were those 50 years of age or older, those with symptoms of neurogenic claudication for at least 3 months, with imaging-confirmed spinal canal narrowing, those able to walk without assistance for at least 20 meters but less than 30 minutes, and those who were able to perform mild to moderate exercise, and those who were not likely surgical candidates in the next year. Exclusion criteria were those with previous back surgery, cardiovascular disease, osteoarthritis of the lower extremities impacting walking ability, or those with psychiatric disorders. There was a total of 104 participants who were randomly allocated, 48 assigned to a comprehensive program and 51 to a self-directed program. The comprehensive group was the chiropractic patient group that received education, a structured exercise program, and manual therapy. The self-directed group received an instructional video, workbook, and pedometer, as did the comprehensive group, but had only a single training session with an independent chiropractor, one not involved in the treatment. So what comprised the structural comprehensive conservative training program? Participants were scheduled to receive 2 15 to 20-minute treatment sessions per week over a 6-week period, followed by a single session 4 weeks later. They were scheduled as regular patients at an outpatient hospital clinic with treatments provided by licensed chiropractors. There were 3 components: education, exercise, and manual therapy. For education, participants received one-on-one instruction on self-management strategies using a cognitive behavioral approach, including how to manage symptoms using problem-solving, pacing, and relaxation. Participants were trained on body positioning to reduce the lumbar lordosis and increase spinal canal diameter when walking or standing. And for exercise, participants were given a standardized set of 18 exercises demonstrated and prescribed gradually over 6 weeks as part of a structured home exercise program. Participants received instruction on stretching, strengthening, and conditioning exercises directed at improving overall back and lower extremity fitness and facilitating lumbar flexion. Stationary cycling in a forward bent position was strongly recommended as part of the daily home exercise routine. Typically, the recommended cycling duration was 5 minutes at week 1, increasing by 5 minutes each week to a maximum of 30 minutes. The cycling and exercises were to be performed twice daily at home. Participants received a pedometer with instructions to record once weekly the maximum number of continuous walking steps they could perform before stopping due to neurogenic symptoms. And for manual therapies, side posture, low amplitude, high velocity spinal manipulation, joint, soft tissue, and neural mobilization, and lumbar flexion traction and manual muscle stretching were applied and replicated at each visit. For the self-directed group, participants received the same instructional video, workbook, and pedometer, plus a single 15 to 30-minute training session with an independent chiropractor not involved in the treatment of the comprehensive group. The aim of the single session was to describe the structure of the 6-week program. There was no personalized education or instruction, no cognitive behavioral interventions, and no manual therapy or other interventions provided to participants. Now to outcome measures. The primary measure was walking distance measured at 6 months using the self-paced walk test, which measures distance walked without stopping for a maximum of 30 minutes. The primary outcome was the proportion of participants that achieved at least a 30% improvement in the self-paced walking test from baseline. There were many secondary outcome measures, including the Zurich Claudication Questionnaire, Numeric Pain Scale, and Fall Efficacy Scale. And now the results. At week 8, improvement in the self-paced walk test from baseline in the comprehensive versus self-directed group was 501 meters versus 201 meters. At 3 months, 487 meters versus 220 meters. At 6 months, 564 meters versus 175 meters. And at 12 months, 675 meters versus 201 meters. The comprehensive group demonstrated statistically significant and clinically important improvement in the self-paced walk test compared to the self-directed group at each follow-up period. At 6 months, the mean adjusted difference in distance walked between the comprehensive and the self-directed group was 421 meters. And at 12 months, the between-group adjusted mean difference was 473.2 meters. At each follow-up, the proportion of participants who improved their walking distance by at least 30% was significantly higher in the comprehensive versus the self-directed group. At 6 months, 82% of participants in the comprehensive versus 63% in the self-directed group achieved this 30% improvement. The treatment effect persisted at 12 months in favor of the comprehensive group, with 81% improved versus 59% in the self-directed group. Significant improvement in pain and function was observed in both groups at each follow-up. At 6 months, the comprehensive group showed statistically significant and clinically important improvement in the walk score compared to the self-directed group. At 12 months, the comprehensive group showed statistically significant improvement in the Zurich Claudication Questionnaire. These between-group differences were clinically important. So as a summary, this is a well-designed and executed study on a key group of patients seen commonly in chiropractic and orthoneural offices. Given the natural history, the risks and expense of surgery, and the significant improvements seen in this study at 1 year, the findings are strong encouragement to attempt a comprehensive conservative approach first for select individuals prior to referral for surgery. Other studies might focus on the specific treatment effects of the manual therapy approaches versus exercise to determine the best mix of approaches.